Hello and welcome to Chewing It Over, and you will notice that this is not the face of Jack Chew. This is hopefully going to be a regular feature where I am going to take over on some Tuesdays, and we're going to talk about some topical things in rheumatology. I've got a couple to go for this week that have been in the news relatively recently. Just looking at my connection, and it's looking all nice and stable, so hopefully coming through nice and clearly on visuals and audio. And I have got this trying out this little new feature today, which you'll see hopefully on this side. My camera's reversed on this side, where we're going to be able to see the chat if you're watching on Facebook or YouTube. Hopefully that chat will display over on that right hand side. You can see what comments are being made. So hopefully you are all aware of who I am. My name is Jack March, and I run Rheumatology.physio, and of course work alongside Mr. Chew on the Physio Matters podcast. So I am going to be asking you a couple of questions today, and one of those questions is, what is it that you are going to do about delays to diagnosis? And I'm hoping to generate a little bit of chat around what's going to be changing in your practice and what the things that you try to do to make sure you keep on top of CPD and are aware of those conditions, which are maybe a little bit rarer, a little bit more difficult to pick up, and are, adversely affected by things that happen during delayed diagnosis. So if we take in a rheumatology context, for example, we know that spondyloarthritis is adversely affected by delayed diagnosis, and the longer you take to be diagnosed, then the unfortunately the more damage occurs to your spine, more fusion, and the worse symptoms are, more medical use, more medical appointment use, I should say, more drug use as well. Requiring sort of stronger biologics and things with regards to managing the condition. So it is important that we recognize those conditions early and get people referred as appropriately. So hopefully we'll get some good comments into the chat bar, and you can tell me exactly what it is that you've done in relation to some of those topics. I haven't had any messages coming through saying anybody's struggling with either audio or video, so fingers crossed it is coming through okay. Please do let me know if it is a struggle. I've tried this before and unfortunately had an absolute shocker of an internet connection, but fingers crossed we are doing okay. So one of the things that tipped me onto talking about this today on the live stream was hopefully everybody saw, or a lot of people saw, the story housed by, it was BBC News. Oh, Joe Turner says all good, excellent. Or love it when that happens. Housed by BBC News about Talia Dean, and I apologise to Talia if that is not how you pronounce her name, but she is a singer-songwriter. And she has been relatively recently diagnosed with axial spondyloarthritis, although she's had symptoms for a very long time. She unfortunately is now restricted from being able to dance and sort of lots of functional things with regards to that sort of thing. And it's a really fascinating story to read with regards to the journey, how she started with her symptoms at quite a young age, but 16 or 17, and then the symptoms went away for a while, and then they returned. She had lots of therapy input, but was never referred for further investigations. And about approximately 15 years later, where we are now in 2020, she was diagnosed with axial spondyloarthritis. She's got a lot of pain, a lot of structural change in her spine as well. And what strikes me about this is, although Talia has obviously managed to make it into the media with regards to her story is not unusual with regards to these conditions. So it is commonplace, unfortunately, for your average delay to diagnosis in spondyloarthritis to be about 6.5 years for men and about 8.5 years for women. So unfortunately, her story is one that is common rather than unusual, and we don't really want that to be the case. So I think part of my job, as I suppose, for creating rheumatology resources, is to make people aware of that that delay to diagnosis. But also, I think we need to take some responsibility on with regards to ourselves to ensure we're doing all we can to make sure we know everything we can about those types of conditions. So interested, anybody pop into the chat whether people have seen, whether that's their experience of these delays to diagnosis, especially in axial spondyloarthritis. And if you did have that experience with a patient, then what did you do then to try and prevent that from happening again, or happening on your watch, as some people would say? Certainly it's something I've seen a lot of over the last decade or so being in rheumatology, and unfortunately there was a systematic review published tail end of last year that looked at these delays to diagnosis, and unfortunately when you match the studies to when they were published, we haven't improved on that delay to diagnosis either. All we've done is become more accurate at recognizing that it exists and how long it is, but it hasn't actually reduced over that period of time, which isn't painting the medical profession, I suppose, in the best light, which is rather unfortunate, because if you take a look at things like psoriatic arthritis, rheumatoid arthritis, we've got some good reduction in delayed diagnosis with early access pathways and recognition, and work to recognize those in clinics, and certainly sort of GP surgeries, physiotherapy clinics, etc. And it seems to be a challenge of multiple directions with regards to axial spondyloarthritis. So obviously it presents predominantly with back pain, and there's an absolute ton of back pain out there. So we've got to pick through that needle in a haystack. We also are driving towards reducing medical investigations. We know that medical investigations aren't always the most helpful thing for patients, in which case we're looking to try to rule out medical conditions as much as we can without using those investigations. But also by terms of with women, such as in Talia's case, historically we've seen these conditions as diseases of men, and that is not the case at all. So while I don't think it is quite even with regards to the prevalence, men and women, it's certainly very close. So the nearest I've sort of seen is about 1 man to every 1.5 women. So we're looking pretty close. And if I think back over my career, how many women have I referred to rheumatology to rule out spondyloarthritis? It's far less than it is men. And I have a suspicion that that is the case across many professionals as well. So I'll just a little question into the text boxes. If anybody's got any comments on if you do refer, how many do you think you refer an equal number of men as women to rheumatology services for axial spondyloarthritis specifically? And one of the things I think is very important to point out is that women do present differently with their axial spondyloarthritis symptoms compared to men. And as a result, I think people, coupled with the assumption that it is a disease of men, then those two things do offset to give you that much longer delay to diagnosis for women than it is for men, which is obviously a untenable position for us to continue with. We need to improve that. There is a good lot of work at the moment with regards to the NASS societies, the National Axial Spondyloarthritis Society. They've got some really good work trying to reduce this delay to diagnosis, producing resources. They've got a campaign as well called a gold standard time to diagnosis, where they're aiming to reduce that right down in all walks of where the patient might arrive. So if you think about a patient's journey from first starting to get symptoms, and I think we have to be careful where we lay these delays, because not all of them lay at the medical professional's feet. Obviously, if a person never turns up in front of a therapist or a GP, then of course no one's going to be able to refer that person. So I've met patients who just put up with their back pain for 5, 6, 7 years before they even went to the GP about it. So some recognition work within the media and things like that Talia Dean's story will help that sometimes your symptoms are related to something that needs looking at. But also, I think just as importantly, if not more importantly, medical professionals need to be well aware of the signs and symptoms. So when someone presents to them in clinic, they're aware of the markers that might make you suspicious of a spondyloarthritis, which needs ruling out by a rheumatologist. I've got a couple of comments coming in here, which is good. Pia on YouTube says, no personal experiences, but I've heard my teachers and doctors talk about spondyloarthritis. And I think this is one of the things that I would mirror across some of my courses that I've done. Therapists, physiotherapists being the sort of the mainstay of the people that I teach, seem to be aware of conditions like ankylosing spondylitis. But that's a specific form of spondyloarthritis. And if you just look out for that as a particular condition, then you will miss other presentations, especially in women, as they tend not to present the same. It's one of those things where you need to be aware of the whole raft of presentations. So the way that I teach my courses and advise therapists to consider these inflammatory back pain issues is, rather than to try and hone in on a specific diagnosis, it's to bring in a real systems type thinking approach. So you end up thinking down the lines of, does this patient need referring for investigations, and why is that? So you end up going, they've got this raft of symptoms which might relate to inflammatory symptoms, but they've also got these associated conditions, things like iritis, uveitis, Crohn's disease. They've got those associated conditions that they might think, okay, right, adding all those things together, this patient has a high suspicion of having an inflammatory spinal problem, of which spondyloarthritis, ankylosing spondylitis are different types. So it's, rather than trying to hone in exactly the right way, because we know that patients are individuals, and we also know that they don't fit these medically defined diagnostic boxes, which research and studies tend to define to try and bring out common threads of approach. So we do have to take these patients as individuals, and then it's then taking that and then a step further. It's, once you recognize that, what do we then do with the patients? And I think we can take a lot of information from things like cauda-equina syndrome, where there's been loads of work pushed through about when you suspect someone of having cauda-equina syndrome, then what are the next steps that you go through? And while spondyloarthritis is not the same medical emergency, or the same time frame of medical emergency, it is still a medical problem. It's not a physiotherapy problem. It's not an osteopathic problem. It's not even a GP problem. It's something that needs to be referred into rheumatology for differential diagnosis and ruling out and treating appropriately. Katie says, struggled to get recognition with a patient, even though suggested straight away. Eventually it's deteriorated, now waiting to go on biologic, and though it's taken 2 years with some private intervention with MRIs, etc. Concerns me that unless they're prepared to be a little bit pushy, they can still be overlooked. And I think this is an unfortunate issue, and one like this patient, unfortunately, as in a lot of things in life, you can get around things by utilizing access. So people that do have private health insurance or can afford to go privately, or even within a postcode lottery, where they may have a GP, for example, who's particularly interested in these kinds of conditions, then it can be rather easier to navigate the system. And of course, that fits into the patient as well. So if they're prepared to push really hard and advocate for themselves, then sometimes that can get them around any blockages as well. But is that really an appropriate thing to make some people do? And I would suggest not. We need to be accurate and equitable with everybody who needs these investigations and referral onwards. One of the things that I, again, thought on my course is what I do is we discuss how do we frame referrals and how do we navigate various referral pathways, because they do vary. And one of the things that I would stress to people is you need to understand what the referral pathway is in your location into rheumatology. So again, my suspicion is all therapists will know exactly what the Cauda equina referral pathways are in their location. Now, admittedly, they're very, very similar across the whole of the UK. However, in rheumatology, they can be very different. So it might be that the rheumatology department is not direct access. You have to go through something like an assessment clinic. It might be that you go on different pathways depending on your presentation. So some rheumatology departments have spinal pathways, some have early arthritis clinics. And it's about understanding what pathway your patient needs to go on in your location. If you live somewhere like I do, on the border of multiple CCGs, so I can, within a relatively small mile distance, the patient might go through 3 different CCGs, and they all have different referral pathways for their rheumatology departments. So unfortunately, that can be a little bit onersome to understand, but once you know that, you can phrase your referral letters. Even if you're in private practice referring out to the GP or back to the GP, you can phrase your referral letter in the appropriate fashion. And what I always suggest to people is that you can't force someone else to make a referral. So if you've got to refer to the GP, you've got to refer to a musculoskeletal access clinic, whatever it is, then what's going to happen is someone else is going to pick up those signs and symptoms, make their clinical decision whether to refer on or not. So in the end, what I suggest to people to do is, and it sounds rather cynical, but if you protect yourself and you phrase things like, I believe this patient warrants a referral to rheumatology, or the symptoms are strongly suggestive of inflammatory pathology that would warrant referral to rheumatology. In that way, what you're doing is you're making someone go against your clinical recommendation, which, if there are any complaints or any problems in the future, it's going to stop there. It's not going to come back to you. But also, what it does is it ensures that the person understands exactly what you're doing, or what you want to happen, or what you're asking to happen, without you making a demand. I know that if I get a referral from someone, let's say this patient has knee pain, please give them quadricep strengthening exercises, immediately the autonomous practitioner in me goes, well, the last thing I'm going to give them is quadricep strengthening exercises. So try not to be demanding or didactic in those referral letters as well. And then what I do is, I'm lucky in the private practice that we work in at Choose Health, I provide the patient with the clinic letter, so they have all that information for them to take to the GP, so they can advocate for themselves as well if necessary. And unfortunately, it is still that kind of situation where sometimes you do need to advocate for yourself as a patient, whereas probably we shouldn't really have to do that. So I think, if I was to make any suggestions from, and I obviously speak to quite a few people who come on my rheumatology courses, and of course they're self-selecting. As soon as they choose to go onto that rheumatology course, they're probably already thinking along the lines of whether they're well aware enough of these types of conditions that if they had someone present to them, that they could appropriately manage to differentially diagnose and onwardly refer. But I think what the flavor of comments I get from them is that once they've been through my course, they realize the complexity of the presentation of the problem. And most people will then think back and realize that there are some patients they probably should have referred into rheumatology at some time, especially women, like I said, with their complex presentations. So I think it's about, in your clinical practice, could you confidently say that if a relatively complex presentation of spondyloarthritis turned up in your clinic, do you think you would recognize that condition? So which by, I mean, some, especially like I say, women, some presentations will arise where they only have tendinopathy at this current time. So they're attending for a tendinopathy issue. There was a good tweet the other day, was tagged at me, which it said the female patient, age 38, and she'd had plantar fasciitis for 18 months. And they were struggling with rehab, not improving. And immediately my brain, now you could say I'm over paranoid, but immediately my brain goes to, is spondyloarthritis should be in that differential diagnosis. That's a chronic tendinopathy not improving with rehab. And then bit more in-depth questioning, it turns out that that patient did have an inflammatory eye issue in the past, and a couple of other tendinopathies as well. So once you start to dig that little bit deeper, then you realize that actually that in all likelihood is a presentation of a spondyloarthritis, in that case probably a peripheral spondyloarthritis. But it's about, I think a lot of therapists will recognize a barn door presentation, and those are mostly going to be men, so they're going to turn up saying they've got lots of spinal stiffness, they're better with activity, worse with rest, better with non-steroidal anti-inflammatories. But it's those fringe cases where the differential diagnosis just falls down that little bit. And the other thing that I think a lot of people aren't recognizing is that if you're referring to rheumatology but you never get anybody back who's negative, so you've referred someone who you suspect of having spondyloarthritis and it comes back from rheumatology saying it's not, then are you referring enough patients? Because if you think about almost every other walk of life with regards to our differential diagnoses, cauda equina, for example, almost all of them come back not cauda equina syndrome. So are we being thorough enough with our investigations and our discussions with the patient? And personally, I think probably not. But also, are we overconfident in ruling out those spondyloarthritis presentations? Which I think we quite possibly are. That doesn't mean that we should be then referring all of our patients on to rheumatology, but it might mean that actually what we start doing is having more clinical conversations with our colleagues. What do you think of this patient? This tendinopathy patient's not improving, or this patient's got a bit, her back pain's a bit unusual. It doesn't quite fit a pattern that I'm particularly confident on diagnosing. And keeping an eye on what's happening with these patients. I think Andrew Cuff, who I do some teaching with, phrases it very well, that we don't rule out red flags, we stay vigilant to them as we progress through with our treatment. And it might be like that lady I mentioned with the plantar fasciitis, that actually in the first 6 months, it's not really something that we're going to be concerned about. But actually, as it deteriorates or stays chronic and doesn't respond to rehabilitation like we would expect, then what we do is those other differential diagnoses become a bit more prevalent or a bit more likely. And certainly I've seen patients who I've treated for a while, and even one chap that I can remember who I treated I treated him in about 2012. He turned back up in my clinic in 2016, and in between times, he definitely had spondyloarthritis the first time I met him, but he hadn't volunteered or wasn't aware of the fact that he had a family history of quite a few inflammatory conditions. And that would have been sufficient enough for us to think actually that probably was a spondyloarthritis at the time. Whereas first off, he just had a few months of plantar fasciitis and got a bit better with physiotherapy and was happy. Whereas actually, had he volunteered or had he been aware of all of the inflammatory issues that he already had, then we might have treated him differently. And 4 years later, it wouldn't have been the case. His diagnosis had been delayed by 4 years. So we can't take everything on the chin as medical professionals that we can be perfect every time, but certainly I think we can be better. And I want to make sure that all therapists are ruling out, even if it's quite quick, ruling out spondyloarthritis in all tendinopathy patients and all back pain patients. And that might be as simple as that the patient fits some other very specific pattern that's quite clear. But I don't think that simple start is being ticked every time by therapists. I think that first hurdle is where people are falling down. They're not considering it early enough within their reasoning, and then there's other symptoms that they get distracted by, or they fit it into another pattern or something. Whereas actually, had it been on the forefront of their mind every time and making sure, much like we do with cauda equina syndrome, as soon as someone comes in with back pain, we're asking all of them about urinary symptoms, all of this every single time. And I think we should be doing the same thing with spondyloarthritis patients. We should be making sure we rule that out every single time. And again, with cauda equina syndrome, it doesn't take very long. As if they have no symptoms or nothing suspicious, then it doesn't take very long for us to rule that out. And the same thing with these spondyloarthritis patients. But then once you start to ask further questions and you start to recognize these symptoms, then we need to know exactly what we're doing with them. And I think that's the other thing where I see that second hurdle, people recognizing that they don't think it's probably not regular mechanical or whatever we call back pain these days, probably not that, but actually what's that next reasoning step? And I think a lot of the time with therapists, it's just lacking that little bit of nuanced knowledge about the associated conditions and asking enough in depth about family history and associated past medical history. So a little bit of a rant from me today. A little bit quiet on the old chats. I don't know whether that's because they're not coming through from the from the various social media feeds, or whether people just are not so interested in interacting with me today. But never mind, that's absolutely fine. I've managed to say my piece, and I'm quite happy about that. So we will be, if you have missed most of this chat, then it will be out on the it will be available on the Facebook page, on the Physio Matters Facebook page. It'll also go out on the Chewing It Over podcast feed. I'll put it up onto my website as well, and on my podcast feed later this week. And if anybody does want any further information about especially spondyloarthritis, but the other rheumatology type conditions as they relate to MSK practice, then you can find information on all of that on my website, rheumatology.physio. There's loads of learning resources on there now, most of which are free, and many of which there are some which are live, some which are recorded, and there are some which do help me to continue these mental projects that I come up with and the other Jack comes up with. And don't forget, I am going to do this regularly, so looks like it might be regularly the last Tuesday of the month. So if you are interested in rheumatology type issues, then please do join me again in about a month's time. Thank you for tuning in, Susan. That's gonna pop your comment up there for us before we finish up. And yeah, anybody wants me to particularly comment on anything or discuss through anything that they've seen in the media, I do get tagged quite often on Twitter about various different things. Always happy to see news articles, new journal articles that I'm happy to comment on, and I'll bring those to these meetings as well, these live streams. So thank you very much for joining me today, and hopefully you will enjoy these takeovers, which are going to be most Tuesdays. We're going to have, I know that there are some others lined up. The First Steps team are going to be talking about what they do. Brilliant team them, so that should be really good. And I will see you next time we have a live stream. Now, if anybody watches these regularly, you'll know that when I turn the music on, it does rather deafen you. So you might want to use this opportunity right now just to turn the volume down. And I'll see you soon. Thank you for tuning in.